crucial and compliant coding of COVID-19 cases. So as Ray mentioned, hi everyone, my name is Victoria Hernandez, and this is just a quick little mini bio on my background. So I will go ahead and just skip on that so we can get to our disclaimer followed by our agenda. So this slide for the disclaimer is just something worth sharing, and to address that the material that we'll be covering today, it's designed and provided to communicate information about medical coding, clinical documentation, and compliance, especially specifically to COVID-19. And I am not providing or offering any legal advice, but more so on practical and useful information, along with tools that will be provided to you to achieve compliant results in the area of COVID-19 medical coding, some data quality, and clinical documentation. And every reasonable effort has been taken to ensure that the educational information provided is accurate and useful. And lastly, granted that different sizes of different organizations, number of beds from private practice, different settings, inpatient, outpatient, of course, applying best practice solutions and achieving results will vary in each hospital facility and clinical situation. Okay, so our goals and objectives for today, we'll be reviewing first the background and statistics of the coronavirus disease 2019, also known as COVID-19. And we will be diving into the coding guidelines and also the latest updates. So we have updates that are fresh off the press that we'll be using effective October 1st. And then we will be practicing on some actual case scenarios. So we'll be looking at some best practices on coding them and also doing altogether other diagnosis-related codes to COVID-19, such as manifestations, history, sequela, and so on. And lastly, questions and answers. So please feel free to also send questions to me via email, which will be at the end of this deck. Okay, so the agenda will be going over the background first of coronavirus disease, followed by the statistics. So the impact of this and how come so many changes, especially in healthcare, hence impacting the medical coding and pretty much just capturing the documentation and tracking all the data. And then we'll be looking at the ICD-10 CM coding updates, along with some very useful coding and auditing resources and references that I feel you may find very useful specifically for COVID. And then we'll be looking at some practice case scenarios for us to code. Okay, so let's go ahead and get started with the background of the coronavirus disease 2019. So origin and background. So we all know it as COVID-19. So in its full term, it's coronavirus disease 2019. Now, the origin of the disease name, it really came from the World Health Organization, WHO, and this was first introduced to us and announced in their website to the world on February 11th, 2020. Now, that's when it was announced. However, the COVID-19 virus had already started to spread in 2019. So as far as a breakdown of medical term here, so the CO for COVID starts with corona, which means crown in Latin, and you all know, seen some pictures and drawings and references of COVID. They do have a crown-like appearance, like from the spike proteins of it sticking out. Then the VI refers to the virus, and the D is for the disease. And 19, it's due to 2019 being the year of when this disease started. So the other reference of the virus is severe acute respiratory syndrome coronavirus 2. So you may see these used interchangeably even, but when you see SARS-CoV-2, that is referring to the virus in the COVID disease. Now, it's referenced as a version 2 because we've already had a SARS-CoV-1, and that is from an older outbreak in Asia back in 2003. So that is a different virus from what we have today. So COVID-19, though, which is the SARS-CoV-2 virus, this was first discovered, as we all probably already know, in Wuhan, China, and started in December 2019. So that's when all our travel-related exportation of cases, that's when all that occurred, and then the spreading took place. Okay, severity of clinical presentation. So from that initial COVID outbreak in China, so we're covering from December 2019 to February 11. So that's actually less than 2 months. They had 44,672 confirmed cases already in such a short period of time. And it's just in that region. So they have a breakdown of the severity. So mild would include some fever, cough, chest pain, nausea, body pain, and a good majority of the outbreak that took place in China during that time frame had this category, the mild. So that's 80.9% of the COVID-19 patients were under the mild category. Now then we have severe, it's like no moderate, it just jumped to severe, and then critical. So severe, we're looking at dyspnea, respiratory frequency of equal to less than 30 per minute. We have a blood O2 sat of less than 93, and the PaO2, that's the partial pressure of oxygen, and the FiO2, that's the fraction of inspired oxygen of less than 300. Lung infiltrates, so potentially would end up with pneumonia even, and that's on greater than 50% within the first 24 to 58 hours. And there were 13.8% that fell in this category on our initial patients who came back with COVID-19 from the outbreak in China, at least that group. So this is the second largest percentage. And then for lesser percentage, but still it was there, 4.7% fell under the critical severity criteria. And that's out of the 2,087 critically ill patients, there were 123 or 49% resulted in death. Now we're talking about body system failure, so respiratory failure, septic shock, multiple organ dysfunctions or failure, and up to death. Okay, now the spreading of COVID-19. So there are three main ways on how COVID-19 spreads. So we have that breathing air close to an infected person who's exhaling small particles and droplets that contain the virus. Now, having these small particles and droplets that contain the virus, yep, that's why we're always having to cover our mouth, our nose, and preferably our eyes, but especially when one's sneezing or coughing. And it's interesting because it's not until we had to wear the mask that I personally even noticed, oh boy, I can't stop touching my face sometimes. So this is the part that we all had to train ourselves at, touching eyes, mouth, or nose with our hands that have the virus. Yep, that's an invitation on spreading this and getting sick. So note, COVID-19 may also spread from people to animals, but that's a whole different presentation right there. So now, as far as protecting against COVID-19, this is per CDC, Centers of Disease. We have recommendations to get vaccinated, wear a mask that covers the mouth and nose, and avoid touching the eyes, mouth, and nose, and avoid poorly ventilated spaces or crowds. Yes, wash hands often, use hand sanitizers that contain at least 60% alcohol, and we've all already probably mastered the social distancing, at least stay 6 feet apart. Now, the three main ways on how COVID-19 spreads. So we have, I'm sorry. This is the same slide. I'm sorry about that. Let's just go on to the next one. Okay, symptoms. And this is not the be-all, end-all. So far, this is what is available with all the research, and this is under CDC's website as well. So shortness of breath, dyspnea, fatigue, some coughing, fever, chills, headaches, sore throat, and we've all heard about that loss of taste or smell, and that runny nose, congestion, even nausea, vomiting, diarrhea. So like signs, symptoms of dehydration. And they do give us a little tip off of when to call 911 if symptoms include trouble breathing, new confusion, inability to stay awake, persistent pain, pale, gray, or blue-colored skin. And we're always seeing updates in the CDC website, and we might need to see more we might end up seeing more information as they learn and through the research on other warning signs to watch out for. Now, there is an available self-checker symptoms tool that they have online, so this is the little link. Okay, let's talk about variants detected in the United States. So this is specifically for the U.S. There are already 4 that were identified. Now, not to say that there's not more, but out of these 4, the last one here, the Delta, is the one that we're seeing and hearing a lot more of lately, but we'll get into that in a minute. So first we have the Alpha, and that was from December 2020, detected in the UK. So United Kingdom is when the Alpha was first identified. Then we have the Beta that followed the December 2020, so that was identified January 2021, and that was initially detected in South Africa. And then we have the Gamma. It was here in our United States earlier this year, January 2021. I feel that initially identified in travelers from Brazil who were tested at a Japan airport during the routine screening in early January. So we might not really know exactly the actual source, but it was at least first detected in the United States in January 2021, and this is the background on how they were able to track it, the source. Now, Delta, this is from December 2020, first identified in India, and we did see this in March 2021. That's when we first detected it here in the United States, and we will be talking about the Delta variant. Now, we have the current authorized vaccines that also work on the circulating variants, and ongoing studies by scientists still continue. But we do have at least FDA-approved the Pfizer. Okay, so as far as the Delta variant, what do we need to know about it? So we did see a drastic spike in the new cases impacting the Delta variant. So this was from June, and talking about just a few months ago, from late June to July of 2021. It started off at 12,000 average reported cases within the 7-day average to 5 times more within that. It was actually less than a month to 60,000. So that Delta variant was really spreading fast. And right now in the United States, it is the predominant variant of the virus here in the U.S. So it's very, very contagious. It spreads very fast and causes more infections than the early forms of the COVID-19 virus, aka SARS-CoV-2. Now, we also have the fully vaccinated individuals that can still get the COVID-19, also known as the breakthrough infections. And now the Delta variant also falls under that, where it can still have this breakthrough infection, although it's less often than the unvaccinated individuals. And the illness has been proven or tracked with the data to be less severe. So now data suggests it might cause more severe illness compared to previous variants, especially with the unvaccinated individuals. Now, there are some ongoing guidance and communication available to the public. So we have several, but this is not the be-all, end-all. So we have actually from all different angles, these different agencies. So we have the CDC, the Centers for Disease Control and Prevention, and their purpose, I listed it here. So they provide the COVID-19 one-stop shop of toolkits. There's also guidance documents, videos, library public service announcements, and for those who are traveling, they have all the updates on that. And we also have OSHA, Occupational Safety and Health Administration. So this is more for in the workplaces as far as keeping safety and the health compliance. And we have the United Nations Human Rights Office of the High Commissioner. Now they provide guidance as far as vaccine access, emergency measures, all business and human rights angle. And then we have the FDA, United States Food and Drug Administration. Now it's guidance on documents for the industry, FDA staff, because anytime there's a virus or a pandemic, now they also have to look at also our food and also the medications that are involved with it. We have United States Small Business Administration, guidance on relief options, local assistance, because the pandemic, as we all know, had impacted all the travel, the leaving your home, and actually going to places where you can be with a crowd of people. So that did impact a lot of small businesses. And I'm sure there's many more, so this is just a few. Okay, let's take a look at some coronavirus statistics. So again, CDC is a really good source. So they have this COVID data tracker that is constantly being updated, and they have a wealth of information on there. So just this is a screenshot, and there's the link for the COVID data tracker, and you can actually select whatever information or customize it, and it will come up as a graph, as a pie, as a running chart. So it depends what information you're looking at, in which we can look at in the next few slides. Their statistics in this COVID data tracker, they have total COVID cases in the U.S. or in the world, deaths. How about testing? From lab testing, how many were positive, how many were negative, how many testings were performed, and they even have a breakdown of by state, territory, or jurisdiction. And how about vaccinations? How many have received both vaccinations? How many have received just one? How many have received the booster, the third one, especially for our immunocompromised patients, and how many have not? So they track all that and also create trends and patterns and identify specific areas by territory, jurisdiction, and then they can also identify the need if there's problems like a shortage and whatnot. Now, vaccine types, any new cases, they even put up anything about hospitalizations, including even length of stay, age, gender of the impacted individuals, and there's many more. So it's really good information if you want to find out, at least in your area or your loved one's area. And more on the statistics. So the total cases as of yesterday, so September 27, 2021, we're looking at 42,850,746 total cases. And out of all those cases, we've had, and this is just the United States, 686,639 deaths. And such an unfortunate number. And looking at straight from their website, there's the 42 some million, and it says here that there's still plus almost 31,000 more new cases. And then for the total deaths, we're looking at another 267 new deaths. Now for the vaccination, so just like I was sharing with everyone earlier, they track fully vaccinated. We're looking at 183.9 million are, and once individuals who've had at least the first dose, there's 213.6 million. Now, they even have it broken down as far as the age group, so they have equal to less than 12 years old, they have 18 years old and 65 years old, and so on and so forth. So very, very detailed statistics. Okay, let's take a look at our coding updates on COVID-19. So this one is just a little reminder. So for our little refresher, as far as what guideline, what instruction takes precedence over what. So the third paragraph of the ICD-10 CM official guidelines, so in your book, there's a paragraph that states these guidelines are a set of rules that have been developed to accompany and complement the official conventions and instructions provided within the ICD-10 CM itself. The instructions and conventions of the classification take precedence over the guidelines. These guidelines are based on the coding and sequencing instructions in the tabular list and the alphabetic index of ICD-10 CM, but provide additional instruction. So in a nutshell, the first, this is also maybe just a good tip if you're trying to defend your code assignment and in an internal audit or external audit, let's say. First, you have to follow the instructions and the conventions. So the example of that is coding and sequencing instructions in the tabular or the alpha index, like when you see code first, or use additional code, or code also, or excludes one, excludes two. So all those are the instructions and coding conventions. Now, the second one are the coding guidelines. Now, those are the chapter-specific ones. And then lastly, any other references, like we have AHA Coding Clinic, and also AHA Hicks for HCPCS and for ICD-10 CM PCS. And we also have CPT Assistant for our CPT codes or outpatient codes. So that's your last one. So let's slow down when we code and make sure we are reviewing every single coding convention and instruction as we land our final code assignment. Okay, we do have an update. As you all know, previously we've always had our annual coding updates that take effect October 1st every year. Well, that is going to change now. So CMS and CDC, they made a joint decision to move to twice a year. So now we're going to get one every April 1st along with the October 1st updates. And this may have something to do with a lot of the new codes, especially with the pandemic. We're finding out more, finding and creating more treatment and procedures and whatnot, diagnosis, manifestations. So additional coding updates are being added, revised, or even deleted. So there's a lot more. So I think twice a year is the best approach at this time, considering the pandemic. Now let's go ahead and review the coding guidelines specific to COVID-19. So, and I'm not going to read every single one, of course, but just a summary, and just so you all have the reference for this. But With COVID-19, even in the inpatient setting, as we know, in the inpatient setting, we can code possible, probable, suspected, rule out at the time of discharge as if it was confirmed or established diagnosis. Well, that is not the case for COVID-19 infection. So this does not apply. COVID-19 will only be assigned once it's confirmed, like for a confirmed diagnosis of COVID. And that's the only time you will code it. If it's ruled out possible, we should not be assigning that U071 code, but instead let's assign the signs and symptoms that was documented. And this is also the same concept with HIV infection, influenza, and Zika virus. So all the different viral infections, if you notice. So, okay, sequencing. So just the same concept of assigning the principal diagnosis. So as long as it meets the definition of principal diagnosis, condition established after study. So look at your UHDDS definition in your code book. So if it meets that definition of principal diagnosis, sure, assign the U071. Now, there are other guidelines, so this is not on black and white every time we'll always sequence it first. No, because there are also other guidelines that require certain diagnosis codes to be sequenced first, such as OB or obstetrics section. So that's our Chapter 15 codes. Obstetrics has their own sequencing instructions with their O codes that you have to sequence first. And how about the newborns? So we have, or the perinatal period. So Chapter 16 are perinatal period codes. They also have some sequencing instructions with assigning certain P codes first. And also for sepsis, there's exceptions. Now, sepsis codes, they have guidelines that are applicable to complication codes, such as a PICC line infection or an indwelling or Foley catheter infection, for example. So if the sepsis infection is linked to the specific catheter in this case, then you would sequence the complication code first, which would be the infection, and followed by the sepsis code. So those are just some caveats to sequencing. So, okay, acute respiratory manifestations of COVID-19. So there's actually quite a few subsets on this section. So we have pneumonia, acute bronchitis. So it is just telling us what codes to specifically assign. So for pneumonia, if it's automatically linked to be due to or related to the COVID-19, there's like a combination code is how I look at it. It's a pneumonia due to the coronavirus disease 2019. Now, they also just have to add that on there for acute bronchitis or acute bronchitis due to other specified organisms, then assign, those codes. And if it's that NOS not otherwise specified, so for us to assign that, it really has to have been not specified anywhere else in that classification. So that's when we could assign it as not specific as acute or chronic. And this next slide is still a continuation of the acute respiratory manifestations of COVID. So we have lower respiratory infection. So they tell us to just code the unspecified acute lower respiratory infection. And also acute respiratory distress syndrome, so ARDS, due to COVID. If it's linked to that, you would assign that the COVID code first, followed by the acute respiratory distress syndrome code. Now there's acute respiratory failure. If that's the case, then you would assign the acute respiratory failure code after the COVID-19 code. And you might need to add additional characters to identify whether it's with or without hypoxia or hypercapnia. Now, what about if you see both of these documented, where the acute respiratory failure then turned to ARDS? In that case, you should not be coding both conditions together, or you will get an excludes one note. So instead, you would just assign the code for the ARDS. Okay, and also to cover other non-respiratory manifestations, then you would then just assign the secondary code to that. For example, viral enteritis linked to COVID. And how about exposure to COVID-19? So this is very specific because they have instructions on when to assign what Z code if it's an asymptomatic individual, so no symptoms, or an individual with symptoms, symptomatic. There's something we need to slow down and look at the documentation for that in the medical record. So for asymptomatic individuals, so no symptoms, but they were actually or suspected to have exposure to the COVID-19, we would assign the Z2822, contact with and suspected exposure to COVID-19. So this, I don't know if you all recall, this used to be the Z2828. It's like contact with and suspected exposure to other viral and communicable diseases. So now, after October 1st of last year, we would assign this new code since it's specifically mentioning the COVID-19 and not just other viral and communicable disease. Now, how about for symptomatic individuals with actual or suspected exposure to COVID, but the infection has been ruled out or the test results are unknown or inconclusive? And in that case, they're saying to also still code the Z20822, contact with and suspected exposure to COVID-19. Okay, then now let's see the next one, screening. So screening, we have to be careful. They do not want us to just randomly assign the Z1152 encounter for screening for COVID-19. And it's our actual coding guidelines is saying during the COVID-19 pandemic, a screening code is generally not appropriate. So for the encounters, for COVID-19 testing, which includes those pre-op tests and just the testing, code as exposure to the COVID-19, which is the Z2822. Okay, how about signs and symptoms without a definitive diagnosis? So also just FYI, you will find that I highlighted kind of like aqua blue. That means these are the specific areas that were updated like really recently and will go into effect in actually 3 days. So October 1st of this year. This is what the latest coding updates have for us. So for patients presenting with any signs, symptoms associated with the COVID, such as fever, but a definitive diagnosis has not been established, then we would then just default to signs and symptoms that was documented. We would code that because remember, we cannot code possible, probable, and in COVID cases because it's only reported if it's a confirmed COVID infection. Okay. Now, asymptomatic individuals who test positive. How about that? They have no symptoms, but they tested positive. So according to this, although the individual is asymptomatic, the individual has tested positive and is considered to have COVID-19 infection. So it would code to a COVID infection. And we have personal history of COVID-19. So those who just have history of it, like no recurrence, okay, no current symptoms, nothing, gone. Like that would be assigned to a Z8616 personal history of COVID-19. Another scenario, follow-up visits after a COVID infection has resolved. So we have a couple cases here. So for individuals who previously had the COVID infection, but no residual symptoms or conditions are there currently, but they're being seen for a follow-up evaluation, and their test results are negative. So it's like negative, they previously had it, they don't have any symptoms. Then this is one case where you would assign the encounter for follow-up examination after completed treatment for conditions other than malignant neoplasm. And this is more in the outpatient clinic setting. And then you can also add as a secondary a personal history of COVID-19. Okay, more codes on encounter for antibody testing, but of course it has to specifically document that that patient is being seen for specifically having that antibody testing, and then that would be coded to the Z0184. And we have one new one. This is the MIS, multi-system inflammatory syndrome. So this is coded to M3581, multi-system inflammatory syndrome. But we have a couple of scenarios here. So if the individual being seen has both currently the MIS and COVID-19, you would sequence the COVID first, followed by the MIS code. Now, how about on scenarios where they have a history of COVID, but it develops to the multi-system inflammatory syndrome? So how would we code that? Before, if you all recall, we would code the M3581, the current, the current sequela result, which is the MIS, followed by the B948 code, sequela of other specified infectious and parasitic disease. Well, that actually changes effective October 1st. So if for those encounters before October 1st, 2021, you would assign the B948, but after, on October 1st and after, you would be assigning this U099, post-COVID-19 condition unspecified. Now, how about if they're known to have or suspect to have an exposure, but then they don't have any current infection? Then you would assign the contact with and suspected exposure to COVID after the MIS code. Okay, this one is all new. This is a new update, coding update, effective October 1st, like in 3 days. And this is the one that speaks of the sequela. So this technically replaced the B948 code. So now we are using the U099 code. Now, be cautious and make sure that it is truly documented as a post-COVID code and not current. So if a patient has condition associated with a previous COVID infection, but then develops a new one, well, that's tricky. Then you would code the U099 in conjunction with something. You'd also code the U071 because you are painting a picture of two separate infections that occurred. One, the previous one, and the new one. So, and again, documentation have to support that they're not referring to the same. Okay, there's also a section in COVID for the pregnancy. So we have the Chapter 15 codes, and in these cases, we would have to assign the O code, the pregnancy codes, and that's their sequencing guideline that we have to follow. So that's the 098.5, and you see a dash there because you still need to add additional characters to identify the semester, and then follow it with the U071 COVID code. Same concept for the newborns, but of course it's with the newborns. In this case, you would assign the P code, again, sequencing. So P358, other congenital viral disease, followed by the COVID-19. And if it is a birth episode, then you would need to sequence the principal diagnosis as always, the live-born code, the Z38, followed by the missing characters, whether cesarean, vaginal, in hospital, outside hospital, and whatnot. So, okay, and last section with changes, vaping-related disorders. So I've actually only had to code this one time. So that's new, along with the post-COVID-19 condition that we looked at previously. They added their own little chapter section, Chapter 22, Codes for Special Purposes. So this is new. Okay, let's take a look at our coding references and resources. So as much as I would love to just provide everyone the coding clinic just verbatim, I can't. So if you have that, let's say, in one of your, as a reference or full package reference with one of your encoders, please take the time to read them. There's a lot of reference on COVID and their manifestations and other symptoms, whatnot. I was only able to just provide at least the latest one. So we have as late as second quarter 2021, and I have first quarter 2021, and I just listed the pages. A lot of great information here. And please make sure to also click on any related topics or updates, because sometimes a new guideline or a new directive or new update will be presented, and that will trump the old one. And Coding Clinic usually has that reference in there in each Q&A. So this is, of course, not an exhaustive list. And I went as far as 2020. So we have from test results reporting COVID, from our respiratory failures, we have skilled nursing facility scenarios or long-term care, pulmonary embolism due to previous COVID or current COVID. How about pneumothorax due to a previous history of COVID? So a lot of different manifestations, so not just respiratory, at least not the respiratory listed in the guidelines, but definitely take the time to read this, as it provides guidance on the specific codes and sequencing. We have HIV/AIDS with COVID, negative COVID test results, and newborns with positive COVID. Now, to me, the great resource though is the one from AHIMA and American Health Information Management Association, that's AHIMA, and AHA, American Hospital Association. So they have their frequently asked questions, and this is all specifically on COVID-19 cases. So as you see, they have been updating and revising for quite some time now, and it's very, very frequent. The latest one is like 25 or 27 of August. Now, these are all included in the handouts that were provided to everyone. So everyone should be getting this frequently asked question file, and it has 59 ICD-10 CM diagnosis questions related to COVID and 10 procedure ICD-10 PCS COVID-19 related questions. So 69 questions, and they've been updated, revised, so please take a look at those. And I also provided everyone a copy PDF file of the coding guidelines for both ICD-10-CM and PCS for fiscal year 2022. So hopefully you all find that useful or helpful. Okay, so for this FAQ, this is just a screenshot on what it looks like for first question. And see, like under question number 1, And at the end of the question, it says revise 4/1/2020 or 12/11/2020. So every time anything changes, they do document that, like what revision date it's applicable to. So hopefully you all can take the time to read all the questions, since very good information there. Now, AHEMA also has other tools that you may use. This is available online, and if you look at the references, resources in this PowerPoint deck, I provide all the links back there. So this is a little tool to assist you in capturing diagnosis specificity in related to COVID-19 and its manifestations or signs and symptoms. And the next one, it's more for diagnosis validation. So maybe also in partnership, if you have a CDI team working with your HIM team, that would be great. See, available tools already. And can even customize it on your own as well. And this other one is from AMA, American Medical Association. So this is on our outpatient side. So this is more for the CPT codes. CPT codes apply to outpatient encounters. So these are more for the vaccines. So this is good information as well for our outpatient coders. Okay, let's do some case scenarios here. So our first one, we have a 62-year-old male patient was admitted with shortness of breath, fever, and fatigue. So he tested positive for COVID-19, so transferred into isolation and given remdesivir IV. Patient was hypotensive, his ABGs were abnormal, and labs revealed increased white blood cells showing signs of infection. He received IV fluids, some antibiotics, and he was placed on the ventilator. So the final diagnosis listed were sepsis due to COVID-19 and acute respiratory distress syndrome. So in this case scenario, how would we code this? Okay, so in this scenario, we would assign our principal diagnosis as A41.89, other specified sepsis, and then U07.1 for the COVID-19, and the J80 for the ARDS, the acute respiratory distress syndrome. So this is only asking for diagnosis coding right now. So hopefully everyone got that right. Okay, case example number 2. So we have a 73-year-old patient with history of COVID-19 2 months ago. So I guess this patient had it 2 months ago, but now is admitted with fever, left lymph node swelling, and tenderness. So the final diagnosis listed were multi-system inflammatory syndrome with tachycardia and history of COVID post-condition. Now we're treating these encounters as if they're October 1st, 2022, okay? So in fairness, because we're here to review the coding updates. So we have our MIS and history of COVID post-condition. So what is the correct ICD-10 CM code assignment? So in this case, we will be sequencing the MIS first. So we have the multi-system inflammatory syndrome, the M3581, followed by the U09.9 post-COVID-19. And this was documented in the coding guideline updates, specifically this scenario, actually very similar angle of the scenario about multi-system inflammatory syndrome and post-COVID-19. Now, for encounters before October 1st, 2021, then in those cases, you would use the B948, the sequela of other specified infectious and parasitic disease. But moving forward, October 1st and on, we would be using the U code, U099. Okay, case number 3. So we have a 52-year-old patient submitted with fever, shortness of breath, hypoxia, and coughing. His lab results were positive for COVID, and his chest x-ray revealed a right upper lobe infiltrate. Also, we're looking at in the neighborhood of a pneumonia. So he was given the remdesivir and was intubated and placed on mechanical ventilation. So he did have the hypoxia, shortness of breath, okay? And let's see, the final diagnosis listed were pneumonia due to COVID-19 and ARDS. So we have the patient has pneumonia, and that pneumonia is specifically linked to the COVID-19. And we also have a separately reportable secondary diagnosis of ARDS. So let's take a look. Okay, we would sequence, in this case, the U071 COVID-19 as the principal diagnosis. Then we would assign secondary J1282, pneumonia due to COVID-19, because they did link it. And then we can also report the J80 for the acute respiratory distress syndrome. So no need to code, let's say, the hypoxia separately, because that's integral to the ARDS. Okay, case example number 4. So we have a 51-year-old patient who's admitted with COVID-associated pneumonia. Now, his latest COVID-19 test results are negative, though. So, okay, so we're looking at this, and they did say COVID-associated pneumonia, but the test results were negative, though. So how would we code this? Okay, in this case, we have to, pretty much similar to the previous case, we would assign the U071 COVID-19 as the principal diagnosis, followed by the J1282 pneumonia due to COVID-19. And here's our rationale based on the AHIMA and AHA frequently asked questions document. It's under question number 15. It's the instructional note under U071, which is the COVID-19 code, directs to use an additional code to identify pneumonia or other manifestations. Therefore, when a patient presents with an acute manifestation of COVID-19, such as pneumonia, code U071 should be reported as the principal or first diagnosis, regardless of whether the patient's most recent COVID-19 test is positive or negative. So that's the instruction that we got. So U071 and J1282. And again, everyone should have a copy of those FAQs. Has a total of 61 questions there. They really tried to tackle every single angle of coding COVID, along with manifestations, symptoms, sequela. It's great. It's very helpful. So, okay, case example number 5. So we have a child. We have a 7-year-old admitted with fever, abdominal pain, and weakness. He was diagnosed with COVID-19 2 weeks ago. He was given IV immunoglobulin and steroids. His symptoms improved. Now, the final diagnosis listed were MIS-C and history of COVID-19. So let's take a look at this. What is the correct ICD-10 CM code assignment? So we have history. Okay, we have the 7-year-old is admitted. Okay, we have M3581, same multi-system inflammatory syndrome, and the U099 post-COVID-19 unspecified. So again, our two references, we have Coding Clinic, third quarter 2020, page 14, and that AHA and AHEMA FAQ question number 37. So let me at least take a look at the Coding Clinic. So the question in the Coding Clinic is, a child diagnosed with COVID-19 several weeks ago is now admitted with multi-system inflammatory syndrome in children, MISC, right? Due to COVID-19. The patient no longer has COVID-19. How should this be coded? So at the time, as of January 1st, 2021, NCHS has published new codes. So use M3581 for the multi-system inflammatory syndrome, and assign code M358. No, before it was only 4 characters. This has been expanded, so now we have a 5th character, that one, M3581. Before it was just M358. So they also mentioned the sequela code, the B948 sequela of other specified infectious and parasitic disease. And again, this is only for encounters that were before October 1st. Now, if it's after, then you would code the U099. And that is also on question number 37 in the AHEMA FAQs. Okay, I think this is our last one. So, okay, this is more of, what do you think? This is an inpatient medical record documentation. The final diagnosis says PCR negative. So the pulmonology consult recommended SARS-CoV-2, which is the test, PCR from sputum, but patient was unable to expectorate the sputum. So it looks like it did not happen because it was unable to produce that to be taken to the lab and checked for the virus being present or not. So PCR test, that stands for polymerase chain reaction. So it's like a test performed to detect a specific, or it's like a genetic material from the virus to see if it's positive or negative. So in this case, though, the last line, or the last 2 lines, will treat as COVID-19, PCT negative. So in this case, should COVID-19 be coded? So, yeah, he still, let's see. Okay, per the FAQs revised on April 28, 2020. Please provide guidance on correct coding when the provider has confirmed the documented COVID-19 after the test results came back negative. How should this be coded? Well, if the provider still documents and confirms COVID-19 even though the test results are negative, or if the provider documented disagreement with the test results, assign code U071, COVID-19. So now it falls in their medical decision making as the physician, as the attending provider. Then if they document it, then that's how they're treating it, and then that's how we would code it. So the test result is not apparently the deciding factor on us choosing to code or not to code. It's a documentation of the provider. So as stated in the official guidelines for coding and reporting for COVID-19, code only a confirmed diagnosis, correct, of the 2019 novel coronavirus disease as documented by the provider. The provider's documentation that the individual has COVID-19 is sufficient. So there you go. Okay, lastly, just stay updated with our coding guideline updates. Remember to please review them. They do tell you which areas are new, usually bolded. And remember, these will come out twice a year, on April 1st and October 1st. And also lots of great information with the AHA coding clinics. These come out quarterly. You do need to have a subscription, but you may check with your employer if there's one available with your encoder that you're using. And also the one that provided, hopefully everyone received your copies and takes the time to review that. That's the latest one, fresh off the press. And these are the frequently asked questions. And CMS, definitely, they provide updates, including the subsets of CMS, like Office of Inspector General. They do take a look at what they'll be focusing on as far as auditing in the next fiscal year. So how about CDC? As far as data tracking, the little tool, definitely. And make sure that there's supporting documentation of medical necessity as well, as that will be reviewed. And also just prepare for your audits and any updates from regulatory agencies. So including, let's say, your local MACs. So make sure that all your coding staff, CDI, and physician champions are updated, and also update all your query templates. Do not send leading questions. All your policies and procedures also need to be aligned with the latest publications. So with that, the next two slides shows all the references and resources. I hope you all find that helpful. Feel free to visit them and click on them. It'll take you there and you can play around with some of the data and research.